My name is M Abdel Karim. I work in Cairo University Hospital. I have the honor to be part of the speakers today. Our talk is about anterior pelvic fixation. You might hear us quite repeatedly repeat part of the talks or part of the knowledge. And this is quite intended just to convey a core knowledge to all of you. Right, so the learning outcomes of my talk today is basically to speak about part of the indications for the anterior pelvic fixation, then to the pass through the surgical approach, and then to the techniques of reduction, some pitfalls, and then what the evidence-based literature would suggest. Generally speaking, we have to consider the pelvic ring, the anterior injuries and the posterior injuries never ever to be dealt with in separation. Yes, for the sake of our lecture today, it's only dealing with the anterior pelvic fixation, but we never ever think of the pelvis in this way. We have to consider both the anterior region in combination with the posterior region as well. Think always of the pelvis like the ring. Whenever there is injury in the front, there must be some injury in the back until proved otherwise. And you have to take into consideration before going to fixation, if you are going to have some errors in reduction of one component, this will be actually accentuating and conveyed further on subsequently to other stages. So if you put it from the start right, it will continue hopefully as right. But if you put it from the start in a wrong place or imperfect reduction, this will accentuate the other components of the injury. You have to take into consideration that part of the views, like the anteroposterior view, is basically a static one. So don't rush into conclusions by saying this patient having pelvic stability. No, please don't take that in a rush. You have to evaluate other views in addition to stress views as well, in addition to the other views which has been mentioned and the CT, etc. So what are the indications? Just quickly, as has been said, basically in disrupted symphysis pubis. And again, this number, which is 2.5 centimeter, has been debated in different parts of the literature. But roughly speaking, for now, and we'll touch this on this more in the discussion groups, it's 2.5 centimeter. And this occurs, obviously, as has been discussed by my colleague, Mr. Asharia, in the anteroposterior compression type 2, and in addition to lateral compression type 3, which is basically lateral compression, internal rotation injury on one side, and the other side is external rotation injury, which we call wing sweep injury. In addition to VS, vertical shear, and also the uncommonly encountered but rather difficult injury, which is basically the locked symphysial fracture dislocation. So to sum up again, what are the indications for our talk today? APC2, APC3, VS, and LC3. What about the rami fracture? Most of the time we don't need to do fixation. However, if they are markedly displaced more than 1 centimeter to 1.5 centimeter, or in cases of tilt fracture, or if there is any neurovascular injury associated. What are the options? For the symphysial disruptions, we would fix it by plate or external fixator. Rami fracture, again, plate or external fixator, but also in addition to the lag screw or column screw. What about the tilt injuries? Because of the tilt and rotation of the fragments, we might be able to achieve that through the plates only. So, surgery is exposure. I learned that from Mr. Halawa from the first time I scrubbed with him, and that's his advice, and I always like to follow that advice. So to put anything right, to fix, to reduce before that, if you are not exposing your patient well or your injury well, you can't achieve any of those. So two surgical approaches usually are employed in this anterior fixation: phalange steel incision in addition to the vertical midline. Going through the first phalange steel incision or approach, it's basically we position the patient in a supine position using radiolucent table. We have to make sure that we are able to get the inlet and outlet and unobstructed view of the whole pelvis of the patient. We have to use the image intensifier. we have to train and also get acknowledged to our technician to make sure that he's well acquainted with different views. And also we have to put a Foley catheter, obviously. The first type is phalangeal incision. Is basically a transverse incision about 1 finger breadth, or rather 2 centimeters above the symphysis pubis. We don't prefer to go over the bone. It could be extended laterally as well. And then we go through the skin, subcutaneous, and then down to the linea alba between the 2 recti. And then we divide that. And if we wanted to extend our incision laterally, we have to be aware for the presence of the spermatic cord, basically. Typically, on those cases with severe injuries, we might find one of the recti is totally avulsed from its place. So we could use this axis as well. And then we go behind the symphysis pubis. We have to be aware of the cave of radius, or the space of radius. Behind that is the bladder. We have to dissect that bluntly with our fingers. We have to be very careful. And then we start to put some soap mop or whatever, and then the malleable retractor just to protect the bladder all through the procedure. So again, we go from the front, transverse incision, and then through the linea alba, and then expose the bladder, and then put some homens to retract the 2 recti. We don't like to transect the recti. This is also written in some books, and it was quite accepted in the past, but no longer accepted. The other incision, the vertical incision, which has been shown by Professor Romans, which quite commonly encountered during the trauma and emergency setting, where the other general surgeon or the urologist might have used it. So you'd be able to extend that and use that to fix your symphysial plate if the patient is quite stable to do that. The other approach is basically the modified stop approach, and Dr. Abdullah Hamad is going to talk about that. It's not the matter how do you place your screw, it's basically how to achieve reduction. And in pelvic and acetabular surgery, quite a few surgeons just think too much about how to fix this fracture. Absolutely, this is not the correct way to think. The correct way actually is how to reduce first, because once you get the proper reduction, you could fix it with whatever you have. And to do that, you have to have some armamentarium of clamping. And again, we've got quite a few clamps, and again, Professor M Abdel Karim is going to explain that thoroughly in one of the demo sessions. For our religion, to start with, our beloved forceps, pointed forceps, or as Mr. Asharia would call it, sweetheart, you start by approximating the 2 parts of the symphysial disruption. You could not only use one, but actually you could use 2. One to control the rotation, but also the other one you could control the flexion extension. And again, under vision you would be able to say whether it's properly reduced or just needs more adjustment. And again, be insisting on taking different views, AP followed by inlet and then outlet views. The other way is to use the screw-based, some pelvic reduction clamps or Farabeuf clamps, where basically you put a couple of screws and then hinge on that, use that as anchorage points with which you could reduce your injury. And again, you could be able to reduce, correct the rotation as well as the flexion and extension. Then put your plate, and that's the X-ray. What about the Rheumatoid fractures? The Rheumatoid fracture, as we just said, it could be fixed using the plate, but also in addition to that with the anterior column screw. And again, you have to be aware of the image intensifier use and the specific views employed on that, including the obturator outlet. And again, there is a separate lecture and workshop about that. And that's the view. Whenever you are putting your symphysial plate, you have to make sure that you are meticulously measuring your screw length. All of us have seen quite a few pitfalls and complications resulting from lengthy screws. And some patients might come back just complaining that these screws are quite long and causing some problems. In fact, I've seen some urethral injuries, bladder injuries, and even one of our colleagues just presented a case report, some urine getting out of the wound, of the phalangeal wound just 1 month post-operatively. So we have to be very careful. Don't underestimate pelvic instability. Expect some failures, and failures will happen in the best hand. So don't feel shy or just please augment your anterior fixation with some posterior fixation. As I said from the start, never ever treat the anterior fixation in isolation from the posterior injury. What about the evidence-based literature would suggest as fixation debates? If the lesion could be fixed by external or internal fixation, I mean, apart from the acute emergency setting, what would you use? Quite a few studies suggested that the internal fixation is obviously much more stronger and or more stable fixation in both open book, especially, and vertically unstable model. So the message conveyed, whenever you have the two options, just go please for the internal fixation. Two holes or multi-holes plate. Again, quite a few studies showed at the end that the two hole symphysial plates had a higher implant failure rate and, more importantly, higher rate of pelvic malunion. So please just go for multi-hole. Again, with the 4 or 6, again, it depends on the preference of the surgeon, but also his appreciation for the posterior injury. And before that, think about the posterior injury. Again, I'm keeping on repeating that. This is a very important part of the talk. And also think side of the patient. Obviously, if you are going to encounter one of those 180 kilograms patient, which sometimes we see some Egyptians are, so you have to think about rigid fixation. So I go for 6 holes plate. 1 or 2 plates. Obviously, the 2 plates or the box plate, which combines 2 plates, one on the superior surface and one on the anterior surface, would be obviously stiffer and stronger. But again, no conclusive clinical evidence exists which favors 1 or 2. But hold on, however, we have to take into consideration again whether there is posterior injury or rather very unstable injury or not. Again, in this case, you'd rather use 2 plates rather than 1 plate. And also, if the posterior lesion for any reason can't be surgically addressed, and also in the osteoporotic bone. However, again, I repeat what I said, no conclusive clinical evidence showed that. Think posterior injury, think size of the patient again. There is abuse nowadays of the locked plate all over the body. What about the pelvis? Are we entitled to use the locked plate in every single patient? Absolutely not. There isn't statistically significant difference between the use of locked plate, stability-wise or failure rate-wise, between it and the unlocked plating. So please use it with caution only whenever there is indication, like the very osteoporotic bones. Right, after doing that, are you going to tell your patient, is plate removal essential or not? Again, quite a few studies showed it's not essential at all. But you might face that with especially the women in their childbearing age. Am I going to get pregnant easily? Am I going to have normal labor? Again, the studies didn't show any difference. But the word of caution, there isn't enough studies to comment on that. But again, the case reports have shown that some actually pregnant women have got even normal vaginal delivery after fixation of their symphysial plate. But again, I would personally refuse to remove the plate for some younger females wanting to get just normal vaginal delivery. Is fixation failure clinically important? When we were residents until now, we find some of the great consultants, big surgeons, having fixed some pelvis and then coming back, the patient coming back to you with the symphysial plate has failed. Would you tell the patient that this is clinically important to have to take back you to theater and fix it again? Absolutely not. Please don't do that. Again, unless in this very specific indication, although there is high rate of failure, which actually approaches in some papers up to 43%, which is massive number actually, after plate fixation. But again, they thought that it's not clinically important unless the patient is quite symptomatic. So I hope by now I would have delivered the message, including the indications in both symphysial disruption and the pubic rami fracture, exposure, different phalangeal incision and the vertical midline, reduction and the armamentarium of clamps. We have fixation, different fixation techniques. Most importantly, think about the posterior injury, never think in isolation, and also we would take into consideration the evidence-based literature suggested so far. Thank you very much.
Thank you very much.